avoiding lower tract symptoms of 2 years. He has.
Go to the slide.
He is non-smoker, diabetic and hypertensive. His ECOG score is 0. He also had a history of inguinal lymph node of 1 centimeter, which was noticed on examination findings. Abdominal examination was unremarkable, and distal rectal examination revealed grade 2 enlarged hard prostate. He has renal dysfunction with creat of 1.4 and HbA1c of 9.7, and urine culture was sterile. This is the uroflowmetry which was presented to us last week, and the same patient. He had a mild straining at the initiation of the voiding. But overall, the curve appears okay, sir. This is what discussed last week. Sir.
About the curve.
Sir.
When is the rise to peak supposed to happen?
So within 1/3 of the voided.
When is it happening?
It's quite early, sir.
Quite early.
He has a peak. He has a peak over here also. No, he has.
Peak means when is the maximum peak of the flow, man? Yeah, when is that happening?
Sir, around 15 seconds. Sir.
No, towards.
Time to max flow.
Supposed to happen towards the initial 1/3, towards the middle, or towards the
initial 1/3 of the void.
Yeah, sir. So you have to mention that. It may or may not be clinically relevant.
Okay.
But you have to mention that there is a strain pattern. You have to mention that who's got it wrong.
Yes. The post-void residue mentioned was 42 at the second attempt. So with this, I wanted to proceed with an prescribed prostate biopsy.
So have we done that?
Shubham?
Yeah, yes, sir. Good morning, sir. Yes, the first biopsy was done, sir.
Done cystoscopy. Cystoscopy findings were grade 2 trilobar prostate with normal bladder neck and grade 2 tuberculated bladder with both ureteric orifice normal. His creat is 1.4 with suspected upper fracture.
We have done this last time, but can you criticize the decision for cystoscopy?
We were querying this decision of cystoscopy last time.
Yes, sir. So, Karunakar, what do you have against cystoscopy?
Against?
Yeah, at this stage.
So at this, it will not aid in my proceeding of the diagnosis. Cystoscopy may not help me to proceed. Cystoscopy will not aid me in confirming my diagnosis. Or management, both, sir. So at this point, I would defer to do a cystoscopy, sir. But if rather it is done, I would like to take the findings from the cystoscopy that since he had an creat of 1.4, so I would like to look at the prostate and the extent to the bladder neck as well as the trigone, whether any infiltration is noted. But the findings mentioned it was only at tuberculated bladders. And both orifices were normal.
So I just asked Shivam a question. What do you mean by grade 2 trilobar prostatomegaly, and what do you mean by grade 2
Tuberculation.
Shubham?
Are you there?
Yes, sir.
Yeah, I'm asking you about your slides. So what do you mean by the second line and the fourth line?
How many grades are there? 5, 6, 7, 8.
This is a cystoscopic grading, isn't it?
Yes, sir.
Yes. So how would you grade it cystoscopically? That's what they're asking you.
Sir, cystoscopically, we see the prostate whether it is.
No, have you read about it or you haven't read about it? Just, we don't want to be. If you don't know, you tell us, then we can.
Sir,
See.
not confirmed.
Ah, that's okay. Then you go back and find out how you grade the prostate endoscopically. Anybody knows? They can fill in the blank.
So the grade 1 is non-occlusive. That means prostatic lobes not.
From where to where? Where are you? From where are you assessing this? From where are you assessing the grading of the prostate?
Sir,
What are the proximal and distal ends of these?
so the proximal extent is till the bladder neck, sir.
Then distal?
Distal it is 1 centimeter beyond the veru, sir.
1 centimeter beyond the veru.
Means proximal to.
That means from the external sphincter you are looking at it.
No, sir. Distal, sir.
Yeah, that's what I'm saying. Beyond you are in the membranous urethra or beyond the membranous urethra? Because you said 1 centimeter beyond the veru montana, no? Towards the exit.
Beyond the membranous urethra, sir.
So you'll be sitting in the bulbar urethra to assess the prostate. Because the membranous urethra is only about 1 centimeter in length. It's between the two layers of the diaphragm, perineal membrane.
Sir, I will be keeping my scope at the veru, sir.
Say that. You're saying beyond here, proximal there, you got definite landmarks. From the veru, all these assessments are made.
Yes, sir.
Yes. Because that is technically the distal limit of our resection. Although some prostates may extend beyond the veru, but that you can make out. So your distal landmark is the veru, and from there you decide what? The
enlargement of the lateral lobes and the means enlargement of the prostatic lobes, sir, where they are approximating the each other. The lobes touching on is considered as a grade 1. Means not touching. Lateral lobes not approximating. The grade 2 is lateral lobes being just about to touch with each is grade 2. Grade 3 is gross, means like obvious approximation of the lobes with each.
So, it is not the very name.
These classifications are best given in a book which I don't know how many people have actually had access to or
I was
read.
going to say that they'll have to go to CMC library to read this.
Morning.
Morning. Sorry, I joined a little late.
This
I
is-
told Manish.
This is the Roger Barnes classification. There's a book called Encyclopedia Urology, and that's given in that. So you will find it somewhere. Their grading of the prostate, the rectal grading, the endoscopic grading, all these are there. And now we've got ultrasound grading, all these gradings are there. Just out of interest, this question was asked because it is put grade 2 trilobar prostatomegaly. So,
To my knowledge, there are only 5 existing copies of Roger Barnes' book. One is in your department, one is in your library, one I copied and gave to PGI, one I gave to AIMS, and one I left in St. John's and they lost it promptly.
These are treasured books. I think, if at all you want to have a copy, you'll have to go to some library in Europe or in the United States. Even maybe Loma Linda will have definitely a copy of it because Roger Barnes was a professor there, so he'll have it. Anyway, that's a different matter.
Would I be right in suggesting that they should not use these grades in the exam or?
I think so. I would say that, the thing is that, Manish, this grading and all that is a very variable thing. It's not something that is cast in stone.
Yes.
There are examiners who believe what is the grade and they'll be happy to pass it. So I don't know whether they will be splitting hairs on this sort of thing like we are, but yes, so it's nice to know what these gradings are as long as you're able to justify it. Here, if you mention grade 2, then I expect Shivam to know what is grade 2. That's all.
I would suggest, if all of you agree with me, it's okay you describe something on rectal examination, but don't describe grading on cystoscopy. None of the examiners themselves might know by now what the grading is.
Okay.
Yeah, I would say that, yeah, probably. Unless they ask you, You can just say trilobar enlargement or something like that.
Trilobar enlargement.
Yeah, it's finished.
Median lobes meeting in the midline, something like that.
Something like that if you want to. Anyway.
Sir wants to share that clinical grading of prostate. Meanwhile, I'll continue the discussion, sir. So, at this point,
Manish, Manish wants to?
yes, sir.
Prabhu,
You can see the screen, sir.
No, we can't.
I don't think he shared it yet.
it's not opening, so we'll continue for now. We'll show it in the end.
Okay.
It's come. It came, sir. Blue it came. Blue pen. Okay.
No, don't worry. Let us move on. Open this, keep it on the desktop,
keep it
and
on
then
the
you
side
can
and
share
then-
at the end.
Yeah.
Okay, so Karunakar, you wanted to do a prostate biopsy.
Yes, sir.
Do you want to do anything before that?
Sir, before that, I wanted then.
No, you've got. What's your clinical diagnosis here?
Sir, my clinical diagnosis is carcinoma prostate, sir.
That's all.
Metastatic carcinoma prostate, sir.
Are you sure it's metastatic?
He has presented with scrotal and penile edema.
Probably.
Probably, yes, sir.
Yes. You don't know. At the moment, your clinical diagnosis is based on a PR, and
Yes.
the rest of it is that probably it is related to that. And he's also got a node, so don't forget.
Yes, sir, yes.
Okay, right. Now, because it's an inguinal node and it's a solitary node, you don't know whether this is inflammatory, whether it's malignant, those sorts of things are there. All right.
Does he also not have
Will you go
bilateral
ahead
hydronephrosis?
I wanted to know it, sir, but cystoscopy findings were, ultrasound was not given, sir. Cystoscopy was mentioned, RFA is normal, so I would rather keep it at that place and I would proceed with RAS biopsy.
Okay, now we'll ask you this question.
Sir,
What all could cause hydronephrosis in a patient with CA prostate?
so the
Could be the mechanisms.
tumor extending into the base of the bladder, sir. Proximal extent of the prostatic malignancy involving the base and the trigone, causing the ureteric involvement and hydronephrosis. Metastasis to the lymph nodes, which will cause external compression onto the ureter and the lower ureter, causing hydronephrosis, sir.
Anything else? Anything which happens when there is carcinoma prostate, which can cause hydronephrosis without there being infiltration.
In any case of hematuria causing clot.
No. We are not talking of transient causes. We are talking of causes of stable hydronephrosis, which might increase with time.
Poor compliance of the bladder, sir.
Why did you say he has developed scrotal and penile edema?
A lymph node obstruction, sir.
How does the lymph node get metastasis?
Through the lymphatic drainage, sir.
Through the lymphatic drainage. Are there any lymphatics running across the bladder base? From one side to another?
Yes, sir.
No? So, lymphangitis or lymphatic infiltration into the lymphatics can also cause the same thing. It produces lymphedema
Okay, sir.
of the lower ureter and causes hydronephrosis. You might not see nodes, you might not find anything infiltrating the trigone.
There are 2 or 3 malignancies which are in the retroperitoneum, which are important when we look at infiltrative varieties. That is, they cause an infiltration of the lymphatics and sort of strangle them and produce edema. And classically, we have carcinoma of the cervix. In women, we have carcinoma of the prostate in men. And this is something that the patient may not actually present with. He'll just present with some difficulty in swelling. That's because there is lymphatic obstruction. Without actually any lymph nodes being involved, you won't be able to see those lymph nodes palpable. It will just be a sheet of lymphatic tissue in the retroperitoneum which strangles the lymphatics and causes obstruction. And this is the reason why you also get on a chest X-ray lymphangitis carcinomatosa.
Carcinomatosa, yes, sir.
Yeah. So these are, what I hope you understood what Mohan was asking you. Apart
Yes,
from
yes.
direct mass effect, this is an infiltrative effect. And this infiltrative effect can be extremely subtle.
Okay, sir. Sir, you can see the screen, sir.
Yeah, we can see.
Yes.
Karnakar
Sir,
and Dr. Manish, maybe you can share this with the other institutions so that somewhere they have something that they can refer to and say, this is how we classify.
Okay, sir, we'll do that, sir.
As a gift.
Karnakar is the author of this topic.
Sure. No. There you have to attribute this to Roger Barnes.
No, it's there, sir. Right in
It's
the.
there. Okay.
Right there, Raja Barnes classification.
Fine. Okay.
Let's go to the case.
yes.
We were talking, you wanted to do a prostate biopsy. We said that
Yes.
is there anything you want to do? Your clinical diagnosis was carcinoma prostate.
Yes, sir.
Possibly, you straight away want to go and do a biopsy?
Sir,
Is there a more, shall we say, scientific way of proceeding with the matter in today's world?
sir, but still I need a confirmative diagnosis before going to
We don't disagree with that. We don't disagree with that.
You understand
It's
the
like
question,
saying it's like saying we argued about why a cystoscopy was done at this point, and you said that there did not appear to be an indication, but anyway it was done at this point. We're not saying you will never do it.
Sir,
But there is a chronology of events, and we need to go in a systematic manner.
sir,
We're not saying biopsy will not be done.
yes, sir, yes, sir.
Yeah, so before you put knife to skin, you must cross the T's, dot the I's, etc., etc. That's what we want to know. So,
right up to the 1980s, exploratory laparotomy used to be the in thing for
yeah,
anything abdominal.
correct.
But you rarely see people doing that now.
Yes, sir. But here
In the exam, Karnakar,
Sir.
the exam, please proceed with investigations first. Get all your investigations in order, and then you decide what you want to do.
yes, sir. But
Otherwise,
here
you suddenly in the middle of something, you say, oh, I forgot this, I didn't do this, So work it out.
yes, sir.
Yeah, so
Yes.
what is it that you will do now?
Yes, sir. They didn't mention the report.
Now, what will you do?
If you were managing this patient, somehow cystoscopy was done, doesn't matter. What
Sir.
will you do next? You have to
Before you do
remember,
a biopsy, will you do anything? Will you do an investigation? Will you do a CT? Will you do MRI?
Sir, I told last week also, I would rather go with a PSMA PET scan in this patient. That's why I didn't wanted to.
Karnakar, we discussed this also,
Sir,
the limitations of PSMA PET scan. You see, there are two situations in CA prostate. One is this indolent progress, finally presenting as obstruction or something. And then there is an emergency presentation,
yes, sir.
right? So is the approach the same in both?
No, not same in both, sir.
Not same in both. So will a PSMA PET scan help you in an emergency?
No.
So think about it and see whether you would like to get some imaging done to help you better. As soon as you do all this, the patient is going to ask you what next. You can't tell him you get an MRI done after 3 weeks because they've just done a biopsy.
Sir. Then I would ask for an MRI abdomen and pelvis with whole spine screening, sir.
Yes, don't you think that's a better investigation to do at this point? Especially when you're looking at somebody who's got mets, you want to know exactly the extent of the metastatic disease, you want to prove your point, and then you will proceed in a more systematic manner.
Yes, sir. Sir, should we discuss that PSMA?
One of the things
we
is
got
that
it,
the staging of the CA, the local staging could be quite different after a MRI. I mean, after a biopsy.
yes,
You get the artifacts and all the rest of it. So you might as well do everything while things are cool and then proceed and say, okay, this is the local T stage, and this is the End stage, and that's the end stage. And you've got a clear picture of what you're doing for carcinoma prostate.
Yes, sir.
And we stopped at that point because you went on to a PSMA, and I don't think we agreed that PSMA was the first investigation in this sort of a situation. And that's when Venki's lecture would have come into play for today. So anyway, now that you got, you want to do a have they done an MRI?
Shubham?
Yes, sir. Sir, MRI was done, sir.
Liver is ultrasound.
No,
Last-
MRI?
Last biopsy was, sir?
MRI?
MRI. Yes, sir. MRI is yes.
Yeah, read that out.
Sir, they ill
Yeah, okay, Shubham, proceed.
There is a ill-defined lesion involving the entire prostate with infiltration of bladder base and both the seminal vesicles. And diffuse restriction seen, irregular thickening of the bladder base.
It
There
is
a
not
peri-
diffuse, it is diffusion restriction.
Okay, sir.
Diffusion imaging is a modification of the conventional MRI.
And this is an important finding in MRI. Restriction of diffusion is in favor of
Malignancy.
yes. Okay.
Irregular thickening of the bladder base with perivesical fat infiltration. There is involvement of left vesicoretic junction with associated moderate left hydronephrosis. MR spectroscopy, there is elevated choline peak. Fat plane with the rectum is maintained. Enlarged bilateral external iliac and inguinal nodes. Multiple enlarged left para-aortic and autocaval nodes. And focal sclerotic lesion in the left iliac bone. Levator ani and other pelvic floor muscles appears normal. And in the abdomen, liver normal in size, no any focal lesion. Intrahepatic biliary reticles are not dilated. Portal veins and hepatic veins are normal. Gallbladder is normal. Spleen normal. Pancreas, head, body and tail pancreas normal. Adrenals normal in size and signal intensity. Kidney, both the kidney shows increased signal, medical renal disease. Small cortical cyst in both the kidney. No abnormally dilated loops and aorta and IVC normal.
So what's your staging here, Karnagar?
So the stage will be T4, N1 and M1B, sir. It's involving the bladder base of T4 and lymph nodes into the parietic region, non-regional lymph nodes N1, and the bone involvement is also there M1B.
So now you see, don't you have a much better picture now as to what you want to do, where you want to go? Now you've got a plan. If you had just done the biopsy, you wouldn't have known all this before. Now you are very clear in your mind, okay, this is what this guy has got. And now you've got to decide as to how you're going to treat this patient. And certainly before that treatment, we want to know what is the biopsy report, isn't it?
Yes.
Yeah.
Sir, biopsy reported number of cores. Okay.
What sort of biopsy? You want to ask this question?
A trust-guided biopsy I mentioned, sir.
Yeah, that's true. So you did 12 core, 24 core, 6 core, 4
No,
core?
sir, 6 core was done, sir.
6 core. Is that okay, Karnagar, to do a 6 core biopsy?
Sir, if you are doing a trust-guided biopsy, I would rather go for an systematic 12-core biopsy.
No.
Don't agree with you.
Don't.
You tell me when you will do a formal 12-core biopsy and when fewer cores might be sufficient.
Sir, when PSA is equivocal and suspicion of nodule in the prostate, then I would rather go for a systematic 12-core biopsy. But here the patient is nodular prostate with strong suspicion of malignancy.
So when you know that, why are you saying you want to do a 12-core biopsy? Huh?
They have done trust, that's why.
No. See, trust is different. Trust for a nodule or trust to look for an intraprostatic nodule is different from doing trust as they have done in this case mechanically.
Okay.
Okay.
They have done a trust-guided rectal biopsy.
Okay.
The trust rectal biopsy is put there. They wouldn't have just done finger-guided. They have done trust rectal biopsy.
Yes.
When you have a patient who's got what this MRI shows, metastatic disease, there is no need to go and do 12 cores, because the more number of cores you get, the more is the complication rate. If you are going to do treatment with curative intent,
Sir.
then you would like to know exactly what the nature of the disease within the prostate is. You want 12 cores, whether there are areas, multifocal, this, that, everything. You want to know, because this gives you a better idea as to what's going to be, because you are planning curative. Here, the question is not of cure. You will give him some years to life.
Yes, sir.
So you can do 6 cores, which will give you reasonable representation of what's happening within the prostate. Supposing I said that, the biopsy report was Gleason 3+3.
3+3.
What would your reaction to that?
First one, I will review the slide. I will review the slides, sir, first.
Very good. Okay, you will review the slide. Anything else you'll do before you review the slide? Any other question you'll ask?
We discussed this
Whether
last
all
time
the
also.
whether all the means each core was done separately in.
Sometimes what happens is, in certain areas of the prostate, it may be 3+3. In another area, it may be 4+3. It may be 4+4.
Yes.
So when your clinical picture does not appear to match with what the report is, you got to go back and find out how many cores were taken and take a second opinion.
Yes.
Okay. What is the PSA in this patient?
They didn't mention me, sir, the report. I think Shubham.
PSA was 200, sir.
Yeah, they told
It
you.
was mentioned. It was told last time.
Yeah.
So it's a very high PSA.
Yes, sir.
It's a very high PSA. So when the biopsy reports don't match, then you have to, put on a thinking cap and say, all right, is there something else happening here which I need to find out? But it doesn't mean that the Gleason 3+3 is all hunky-dory. It can still give rise to problems. It can still give rise to problems. And that is why there are some people who would still go ahead and say that Gleason 3+3 is cancer. They haven't removed that term from it. If Gleason 3+3 was not, then the biopsy report should not say adenocarcinoma. It's very difficult to convince a patient, you've got a Gleason 3+3 cancer, but I don't need to do anything about it. Our Indian patients in particular. Sir, you're telling me on one side cancer, and the other telling me don't do anything about it. So it's either the patient's idea of things is different, and we look at it very differently. So there must be a different term used for this, is what I feel.
Even
Anyway.
for us, Gleason 3+3 in either organ confined or in one nodule or 2 nodules here and there is different from 3+3 in a hard prostate where the sulci are eliminated and there are metastases.
Correct. Absolutely. So we got to take all this into perspective when we plan treatment. So what are you going to do? You got the biopsy, you got the MRI. You want any other investigation? Karnagar?
No, sir. I'm okay.
No other investigation. So what are you going to do?
Sir, I will do an. I will advise him androgen deprivation therapy, sir. I would prefer castration, surgical castration, orchidectomy, sir, bilateral orchidectomy.
Okay.
So in the exam, you pause. You say, sir, for this, I want to do androgen deprivation therapy.
Yes.
Let the examiners ask you. Because you say castration, I might be having a good practice of medical castration.
Yes.
So,
in a patient like this, would you like to just stop with androgen ablation, or you want to do something more?
I will add the management, extra management also, sir.
Then why didn't you tell us? You just said I will do castration.
First would be the.
See, that's what Mohan was telling you in the exam. Now you got the picture now. You got a guy who's got metastatic prostate cancer. He's got a high PSA. He's got a good ECOG. All right, he's got a good ECOG. He may be having an obstruction to the urine flow, but he's not worried about that. He's worried about penile edema. There is no doubt that the first approach would be androgen deprivation. Nobody doubts that. So androgen deprivation has to start with first. Now the question is, in this situation, will you go only with androgen ablation or will you add something more? Is what we're talking about. And that, when the examiner begins to ask you questions like this, you must know exactly what are the current status. What are people doing now in patients who are naive, who've never been treated? This guy's got nodes, he's got one node, he's got one bone met, and he's got a prostatic cancer, a hard prostate.
So I will get an bone mineral density scan, sir, to check for the P score. For the P score, sir.
Why, man?
After starting the androgen deprivation therapy, sir.
No,
So
you expect
this thing is monotherapy with androgen deprivation.
No, sir. I will ADT plus my plan would be abiraterone, sir, plus prednisolone.
Hello.
So who will say that?
results with abiraterone.
Huh?
Any other
Amazon.
good ECOG score?
I can. Two options are there, sir, but I will go for abiraterone plus prednisolone, sir. Otherwise, it will be a docetaxel based chemotherapy. Since it is only lymph node metastasis and a single metastate to the bone they mentioned, so I would rather go for abiraterone plus prednisolone. And his renal
Fine, I'll just be back quickly.
Yeah, sure.
creat is also 1.4. Sir, EGFR would be less than 50, sir. This creat of 1.4 in 69-year-old male patient. And he has metastasized to the lymph nodes and mentioned sclerotic lesion in the iliac bone. So my treatment would be ADT plus abiraterone and prednisolone, sir.
Abiraterone plus.
After explaining the patient regarding the compliance and the follow-up, sir, because it has to be taken daily and cost factor also.
Why not a taxane-based therapy?
Why not docetaxel?
Sir, one thing is renal dysfunction, sir. First thing, I would rather just wait on that. And
no, but you manage the renal dysfunction, hydrate.
Okay, it might.
Whatever, and with androgen deprivation, if the tumor burden comes down, the ureter will open up. Is it contraindicated?
No,
or does it call for dose modification?
Dose modification also, not a contraindication.
Yeah, so you got a facility for dose modification, right?
Yes, sir.
So of the two, between abiraterone and docetaxel, which has shown better results?
Docetaxel chemotherapy.
And then why do you want to give something inferior?
So will you be able to tell us the numbers and the studies which support docetaxel? How much does it improve versus abiraterone?
Yes, sir. Docetaxel chemotherapy it was done in Stampede Arm C as well as in charted trials, sir, where they have seen more than 1,200 patients which were randomized to ADT with placebo and ADT plus chemotherapy. So there is an improvement in overall survival by more than 12 months, approximately 12 to 13 months in case of charted study which was been mentioned, and a Stampede of 11 months improved survival compared to ADT alone, sir. In case of Latitude trial, which was described about the abiraterone plus prednisolone versus ADT alone, there is an overall survival improvement by more than 16 months, sir, in compared to ADT group alone. So that is the reason I would rather go ahead with an ADT plus abiraterone or docetaxel, plus or minus.
If you had to do a study,
sir,
how would you design it?
It's a randomized control study, sir. If I design a study, sir.
So what would the study design be? What would the RCT design be?
Blinding, sir. I would ask randomized control study.
Karnakar, come on. We have passed that stage, all of us. When we say study design, We mean the methodology, and we mean the population, and we mean the allotment of cases.
Yes, sir.
See, here the problem is you've got one study which is placebo-controlled, arbitron, and prednisolone.
Yes, sir.
The other study is docetaxel, prednisolone, and placebo. Right?
Yes, sir.
Now, has there been a head-to-head comparison between arbitron and docetaxel?
No, they didn't compare head to heads.
Would that not be the best way of studying which is superior?
Yes, sir. So now they're doing the peace trials.
No, I'm asking you. Wait.
Sir.
My question to you was, how will you design the study?
Yes, sir. I compare head-to-head of the drugs, sir. Rather with the placebo.
And it is not enough if you just compare head-to-head. You also need a placebo arm.
Yes, sir.
For all these studies.
Yes, sir.
Right? So,
yes.
You can be asked these questions in the exam.
So were the baseline study populations the same in both the trials?
Approximately same, sir. 1,600, 1,060, 1,100.
That is the number. The baseline characteristics of all the patients are the same.
All are.
The grade was the same. The PSA, the tumor burden.
No, sir.
Was the same.
There are some are intermediate rates, intermediate risk, and some are high risk groups.
So which is why you cannot deduct from two different studies.
Which is why when they do a meta-analysis, they eliminate all this and do a meta-analysis of like for like.
Yes, sir.
So you either choose a high-risk group. In fact, you would choose a high-risk group because that's of most interest to you.
Yes, sir.
And compare the performance of high-risk groups in both. Because if you're using high-risk, moderate risk, low risk and averaging, naturally the effect will be better if you have more low-risk people in it.
Yes, sir.
Can you list out all the methods of androgen ablation?
Surgical orchidectomy, sir. Medical castration, castration, androgen ablation.
No, it's called medical castration.
Yes, sir, medical castration. Yes, sir. GnRH and agonists, sir, and GnRH antagonists, and anti-androgen treatment, sir.
So you mean GnRH agonist and antagonist both cause androgen ablation? Is that correct?
Any one.
Both can cause androgen ablation.
Yes.
So how would you explain that physiologically?
So it is based upon the suppression of the pituitary by giving the GnRH agonist to suppress the pituitary secretion of FSH and LH. So further leading to decreased expression of testosterone from the Leydig cells. Indirect inhibition.
You explain on a physiological basis, you are giving a GnRH agonist. And when you give an agonist, you are saying all these hormones will get suppressed. So how does that work?
There is an initial rise in the testosterone after giving a GnRH agonist, sir, initially.
So I'll put it differently. I give an alpha agonist and I say it causes alpha blockade. Does that happen? Doesn't happen.
No.
So I'm giving a GnRH agonist and I'm saying it causes blockade. Anybody else can answer this. This is a
basic question.
There is desensitization of the receptors, LH, RH receptors due to the chronic stimulation by GnRH agonist, resulting in decreased FSH and LH synthesis.
GnRH agonist, if it is given in pulse dose, it will cause agonistic effect. If it is given in a loading dose or continuous presence of the GnRH agonist, it will cause.
You are not clear. We can't hear you.
We'll move closer to the mic, please.
In the normal physiology, what happens to the gonadotropins from hypothalamus?
Sir, it will be released in pulse dose to cause it agonistic effect. If it is continuously stimulating, it will cause antagonistic effect.
No, these are important. This will come even in your theory.
Yes.
And definitely in your examination, if you get a case like this, because there's very little else to discuss. Why are we adding steroids unnecessarily? Already we feel there might be bone involvement.
Sir, for the extragonadal adrenal secretion of the because of the action of these GnRH agonists onto the adrenal gland also, there will be production of more ACTH.
Okay.
Production.
Let it produce. What does ACTH got to do with carcinoma prostate?
No, prednisolone is mainly to suppress the expression of these action of these hormones, sir.
You are using abiraterone, no?
Yes.
Sorry,
Sir.
I went off for a minute. So
No, he is free to use both. He says he's got a choice of docetaxel steroid or abiraterone steroid.
you're using which one? You have to choose now.
So steroid is given along with the abiraterone because it is mainly the extragonadal inhibition of the androgen production, sir. So there will be an bypassing of this cycle where the 17-hydroxypregnenolone will be directed towards secretion of the corticosteroids, means production of more ACTH action and hypertension. So for that reason, I would like to give steroids to control that.
You said you want to prevent the androgens generated from the adrenal.
Yes, sir.
Correct. So how do they generate from the adrenal?
So it is by the aromatase.
What are the mechanisms by which sex steroids from the adrenal may get transformed to testosterone?
So dihydroxytestosterone is the endpoint production of the sex steroid in the adrenal gland, sir.
Okay. No, I think you better brush up on this. Okay. The normal pathway and the abnormal pathway, and what happens when you start giving people steroids with, say, abiraterone or with docetaxel. Any other reason for giving?
Basically, the abiraterone blocks the pathway more proximally, and therefore both the steroid as well as the adrenal androgens are suppressed. Okay, when you start off with desmolase, you start off and then you do the 1720 desmolase.
1720 lyase and 1720
lyase to 17 beta hydroxylase, 11 hydroxylase, and then you have reduction in the production of both DHEA, etc., as well as epiandrosterone. And then because it has blocked already proximally at 17 hydroxy, therefore you have steroids also not being produced in adequate. So you have to top it up with the regular prednisolone, otherwise steroid cell. So
yes.
Both have to be given when you are giving abiraterone.
Yes.
What are the other advantages of steroid administration?
Sir, if there is, since these symptoms related to the bone metastasis, like neural compression and the...
Here there is no compression. See, even in a condition like Hodgkin's or non-Hodgkin's lymphoma, along with other drugs, we add steroid. It's got nothing to do with bone compression or with sex steroids, isn't it?
Sir.
Why is it added?
To reduce the inflammatory response, or immune response, to keep it at level.
What immune response?
Interleukin or cytokine response, following in chemotherapy or following in a drug.
Then not to have it if there is a response. Are there any beneficial effects, direct beneficial effects of steroids?
Have you seen patients on steroids? who have had for something, some other, say, retroperitoneal fibrosis and all that, you give RPA, you give steroids, isn't it?
Yes, sir.
Why do you think the GPs love that drug?
No.
It's whacked right, left, and center in our country. If you go to some places, you will find that that's the first thing in the list of prescriptions. They'll throw in a Viceroy also for sure, a small measure. It's a great anti-inflammatory, and the most important is the feel-good factor.
Yes.
The patient feels on a high. He feels as though he's had some, he's had six vodka shots or something like. He feels on a high. This giving steroids is a very old treatment for carcinoma prostate. When we didn't have any of these drugs, we would use steroid as a fallback, and it did give them very good quality of life for a few days, whatever they had. But it was all the feel-good factor, and of course, certainly it did reduce the inflammatory response secondary to malignancy. Whenever there's a cancer, the body is trying to fight it. There's a T cell activity. There's a cytokine storm. There is this. So steroids are given for that.
Yes.
Exactly what's happening to the virus, isn't it? Why are steroids being given? Doesn't cure it.
Steroids also prevent nausea and chemotherapy-induced nausea. They increase appetite, and well-being is important in these people. You're giving them bad diagnosis, you're giving them terrible drugs. There should be something they feel happy about.
Yes, sir.
So, can we go on to the presentation?
Yeah.
Yes.
So you can see the slide, sir?
Yes.
Yeah, we can just see it now. Yeah.
Yes. Sir, I will be discussing in favor towards the prostate-specific membrane antigen PET scan, sir, and discussing.
Won't be speaking in favor.
Means
You'll be explaining to us what this is.
Yes, sir. Yes. Sir, the guidelines currently, as we discussed, were the cross-sectional imaging of CT with MRI with bone scintigraphy, sir. But why? In discussion related to PSMA PET is the lymph node metastasis, the accuracy, diagnostic accuracy of the CT or the MRI in detecting the lymph nodes. You can see that the sensitivity and the specificity is low. Importantly, the sensitivity is low in detecting the lymph node metastasis. So the reason behind would be the picking up the lymph node metastasis by the cross-sectional imaging would be better if the size of the lymph node is more than 8 millimeters based upon the morphological character and the imaging quality, means imaging appearance of the lymph node. But if you see here, it is 80% of the metastatic lymph nodes are of size less than 8 millimeters. So this could be the reason for less pickup rate of the cross-sectional imaging in lymph node metastasis, especially speaking pertaining to the prostatic malignancy. So in this background, why PSMA PET has gone important now is it's a higher diagnostic accuracy. It seems important in the staging as well as the management, both. So few brief points about why PSMA has been chosen, because the normal prostate also expresses the prostate-specific membrane antigen. The exact function of it was not being described. It is localized to the cytoplasm and the apical part of the epithelium in the prostatic ducts, in the normal prostatic benign conditions. Whereas in neoplasia or a dysplasia transformation, there is a transfer of the PSMA from the apical towards the luminal side of the ducts. That itself explains the more expression and the affinity towards the prostate-specific membrane antigen scans, which will give better information. So this is the structure of the prostate-specific membrane antigen. It is a transmembrane glycoprotein 2 cluster. It has a large extracellular domain and then a transmembrane region and an intracellular domain. The importance was initially the positron emission tomography scans were done based upon the ligands being attached to the intracellular domain, sir. Where I can give an example later on, 7E11 was described, which gets attached to the intracellular domain. But these are large molecules, and in case of a viable tissue, they have a low positive predictive value because the taking up of the cell, the ligand inside the cell to attach to the intracellular domain is less. So now they have recently studies were done to develop a low molecular weight ligands. So of them, one of is the PSMA 11 and 617. These are the ligands which will attach to the extracellular domain. So now the PSMA PET scans which we do are those ligands which attach to the extracellular domain. Later it will cause internalization of the tracer which will show the uptake in the cell. So the advantage of PSMA PET is it is expressed more in case of high-grade prostatic carcinomas and metastatic CA along with that of the castration-resistant prostate carcinoma. This being the increased expression and in the high-grade lesions. That is what we will take an advantage in case of a primary primary modality of investigation. And you can see that it is weakly expressed in the normal prostate. So these
just to add, the ratio is 1:1 in normal prostate and PSMA. The ratio is just 1.
Yes, sir.
1:1. Yes.
But 30 folds increase in case 10 to 30 fold increase in case of malignancies. The more than 10-fold increase of the PSMA expression is there in case of malignancies, high grade. And an exception is the neuroendocrine malignancies and those solid tumors which are vascular will have an low expression of these PSMA. The neuroendocrine carcinomas will not have this expression, but it is also seen in case of other solid tumors, which I will show in brief. So these are the glands which can have a normal uptake of the prostate membrane specific membrane antigen also. So studies are being done to project it onto the renal malignancy also in the current settings. Seen the salivary gland uptake, spleen and the intestine, colon, all can have the uptake of the prostate specific membrane antigen study. So before the prostate specific membrane antigen, what were the positive photon emission tomographies which we are using? From the beginning, we got the 11C choline PET scans, we got it. Later on, followed by the fluorodeoxyglucose and the technetium-99 scans. They also picked up the metastatic lesions as well as the malignancy in the primary site. The thing is, the sensitivity is less, especially in level of low PSA, because they studied these in case of biochemical recurrence. I mean to say recurrent prostate malignancy. So there, in view of low PSA expression, the sensitivity of these tests has come down. Hence, we came towards the new radio tracer materials, which I will show you here. So this is the component which we have an nuclear pharmaceutical, which we get it. As I described, we have a ligand, a chelator should be there, and an isotope. So the ligand, as I described, sir, the recent one which we are using is commonly used and available and more affinity to the extracellular domain. That is the urea-based ligand, sir. That is glutamate, urease, and lysine-based ligand. And the chelator will be attached to the ligand in situ. That is a common one is the HPEDCC, which has been expanded down there. And the isotope which we are using currently for the PET scan of PSMA are fluoride and the gallium. So that depends based upon the emitter which we use, whether we are using a cyclotron, or we are using a generator for the production of the radionuclide. Depends upon what we are using that. So gallium 68 and the fluoride 18 are the commonly used for the primary staging as well as the recurrence of the biochemical recurrence in case of malignancy. Technetium 99 is being used mainly to guide the radiological improvement, like following radiotherapy, the response, how it is, and intraoperative, if you are planning any surgeries, means if you can do the technetium 99 scintigraphy and picked up by the gamma camera, if you want to see the lymph node uptake intraoperatively and do a proper dissection. So that it can be useful. Whereas the lutetium 117 and these yttrium are these are beta emitters which are mainly useful in case of theranostics like radiotherapy which we are using. So lutetium 117 and the yttrium indium are being used for that purpose. So these are the radio tracers which we are now commonly being available and being used. Common one I will describe, that is the gallium 68, which is being generated from the germanium generator. The advantage why is being used more nowadays is because of the less cost and the life of 270 days. And we can use it for 2 to 4 patients in a day. But it is been can be used in a small, means like centers where the numbers are high, because we can use it in a day of 3 to 4 patients, and the cost around 20 lakhs per year. Whereas which I described for the fluoride usually is from an cyclotron, sir. So which needs an larger equipment, and as well as you need to have more cost inbuilt also in that. So that is the advantage of the generators. So these will be distributed to the centers where they are doing the scan, so that they can pile up the patients on the same day and finish. So that is the advantage of having the generators. Briefly about the technique and how we do that. So adequate hydration. The furosemide is being given because this prostate-specific membrane antigen is being excreted through the kidneys into the urine system. So the urinary tract, kidneys and the bladder also will show the ability. So since if you want to know the status of the lymph nodes, especially like in this case we discussed, so the Lasix will have give the advantage of draining the urine, so that you can have a better information about the lymph nodes, especially in the lower ureter level, the ILAX what we discussed. And the administration is 1.8 to 2.2 megabecquerels per kg is the standard dose, and is given as an intravenous administration. The acquisition is taken at 60 minutes. That is the advantage. We have a longer intervals to take the images after giving an radiotracer. So image acquisition, there is also a protocol for that. First, as we discussed, it is a PET CT. So they will superimpose the CT or superimpose the PET images on the CT scan. So first they will perform a CT scan from the skull base to the mid thigh, and the PET is acquisited in a reverse direction, sir, from caudal end to the cranial end. So this will take an acquisition duration of 2 to 4 minutes. Then the images are superimposed and we'll get the information. Reporting, as we discussed the technical details and dosage, and important thing we need to mention in the report was the location where it is present, the extent and the intensity of the PSMA avid lesion. That is what important in the reporting. So the degree of the avidity is expressed as standard uptake value. Either the mean or max, what they will calculate, it is based upon a standard mathematically calculated formula, sir. So according to the studies, what they mentioned is a standard uptake value of 3.9 can be considered with more than 95% sensitivity of saying it is a malignancy, sir. So if the SUV comes to up to more than 3.5, that is, say, for example, 3.5 more than that, you can consider that it is a metastatic lesion. That means there is a malignancy in that. So this is the basic about the ligands and the radiotracer and the technique and acquisition reporting. So coming to the indications currently where we can use the PSMA PET scan. We discussed it as localization of the biochemical recurrence, but now the trend is being shifted towards the primary staging also, especially in case of a high-risk prostate carcinoma.
Can you just go back on that slide?
Yes, sir.
I want you to remember, when you say primary staging of high-risk carcinoma prostate,
sir,
please look at that reference. That is very important. Hoffman's reference, the Australian study.
Yes, Australian study, yes, sir.
But read it very carefully. Before curative intent surgery or radiotherapy.
Yes, sir.
Primary staging of high-risk carcinoma prostate before curative intent surgery. What did you say here? The guy, your patient had a PSA of 200. He was not curative intent. That's what I was telling you. When you have curative intent, then these things come into play.
Yes.
Because you want to be sure that you have a high-risk cancer or whatever it is, it picks up nodes, it picks up this, and whether you want to change from surgery to radiotherapy or something else. This is a very specific study addressing a very specific question. It was not just blanket use for everybody.
Yes.
Yeah.
Understood.
Yeah.
So regarding the same question what sir asked, whether the PSMA PET would be better than conventional imaging for staging of high-risk prostate cancer. So this would be the example where we can see he's an 70-year-old male patient with biopsy-proven high-risk prostate carcinoma with a Gleason score of 9 and PSA of 94. You can see the image of A, B, C, where you can see the prostate picking up the lesion in an axial CT and a PET imposed onto a CT. Where here in a DEF image, you can see that the axial CT cannot make out any lymph nodes very obvious. And if you see the PET image here, and I superimpose there is very obvious uptake seen in the lymph nodes, which will change the stage of the disease. And your plan of management also would rather change. So in this point of context, I would rather say that, yes, it would be beneficial to doing a PSMA PET scan as a part of primary staging also. Yes, sir, told if you are planning a curative intent.
Karnakar, can you go back to the image, please?
Sir.
D, this is just a warning for residents. If you see here, there are several soft tissue lesions or shadows which are not normal.
Yes, sir.
Yeah, they're all merged in each other. So here the use of the PET scan is in knowing what is the significance of these.
Yes, sir.
Right? So
yes,
the lesions have to be recognized at CT. I mean, I would be unforgiving of myself if I didn't pick these up on CT or MRI.
Yes, sir.
This is not the normal pelvis.
Maybe to increase the diagnostic accuracy, I can say.
Correct. And to know what they are.
Yes, sir. So what does the impact of PSMA PET on the stage? So this, I'm quoting the study of a retrospective single center study. It is 64 patients where 8 patients are of intermediate risk category and 54 of high risk category. So if you see here, the nodal status as well as the metastatic status was upstaged following an PSMA PET compared to a conventional cross-section imaging in 23% of the patients, and also downstaged in case of 9%. Whereas metastatic status also there is an upstage and significant amount of downstage in case of an prostatic specific PSMA PET scan compared to an cross-section imaging of CT or MRI with a bone scintigraphy. So the level of confidence what they mentioned is when compared to equivocal, especially they're telling there is an equivocal diagnosis. If it is an sure shot diagnosed case of metastasis, it's okay. But if they have an equivocal diagnosis, to say it is a positive or negative, then the level of confidence has been increased with the PSMA PET scan by 20%, especially in case of metastatic disease. Second question is whether PSMA PET will have an impact on management. First we discuss the staging. So around the management. So this is also they have addressed in the same study, sir. So they mentioned that there is a change of plan which they have been taught. They have 3 plans, whether they have undecided in treatment, or they have a curative intent, or they have a palliative intent. These 3 groups they have taken among the 64 individuals. And they are given a percentage of which patients which they have thought initially based upon a CT or MRI with bone scintigraphy. But when you go with the PSMA PET scan, there is a change of 9% of patients to curative when they are thought to be an undecided previous plan. And there is a change to palliative to 3%. And undecided patients also, curative intent was increased up to 14%. So if you see the percentage in their study, there is 36% increase in the treatment category change. So this shows a little significant significance as the treatment management has been changed following an second imaging study compared to a cross-sectional study of CT or MRI. So this is what Ganesh told about the pro-PSMA study, Australian-based study, which was being published recently in Lancet, sir. So these data we have been taken from that study. So here you can clearly see that the lymph node and distal metastasis compared to a conventional imaging, what they speak is an CT. The compared to that gallium PSMA PET scan, the sensitivity and specificity are significant. I mean, to say sensitivity is at least high, and the accuracy also gone up to 92% in both the lymph node as well as the distal metastasis. If they have done an PSMA PET scan. So it is a prospective multicentric randomized study, sir. They have taken 300 individuals and they have randomized them into 2 groups of 150 each. And stage they have taken is more than T3, sir. And an ISUP grade of 4 they have taken. And first group they have randomized as done a CT cross-span bone scintigraphy. And the second one randomization was, this is randomization. Second group were the PSMA PET. And then they have sequenced them with CT group with PSMA and PSMA group with the CT. So they have drawn the results after that. So they mentioned that the sensitivity and specificity are high when you have taken a PSMA PET scan. So here you can see, sir, here also in limiting the equivocal results when we have a decision whether we have to have a curative intent or a palliative intent. So if you see the equivocal findings on first line diagnostic image, if you take the CT where the blue arrow, blue mark being shown, there is equivocal percentage up to 23%. But if you take the PSMA PET scan as a first line imaging there, the metastatic disease, the equivocal chances are reducing significantly. Sir?
Hello?
Sir, can you hear me?
Yeah.
Yes, sir.
No, carry on. He's speaking to someone else.
Yes, sir. So that equivocal nature in a metastatic disease has reduced to 7%. And it is also very significant in case of pelvic lymph node metastasis, where 6% are equivocal in case of conventional imaging of CT, and less than, almost close to 1% in case of an PSMA PET. So this obviously will change the management of the patient. And even distal metastasis also, there is 21 and 7 difference in equivocal patients. Same thing in case of management also. If they use first line diagnostic imaging as an CT and the first line imaging as cross-section of PSMA PET scan, the management percentage also has significantly increased, like more than 10% change in the management here. And the significance is second line. Say for example, a patient has been done a cross-section imaging of CT and you have subjected him to a second line test of PSMA PET after doing a CT. There is significant difference of 5 to 25, 25%, 20% significant change is there.
Imran, can you mute your mic, please? Imran Khan, please mute your mic. Yeah, go on.
Yes, sir. So if the second line imaging after CT you are doing a PSMA PET scan, there is significant change in the management percentage, sir, where 5 to 25% difference you can make out there. Okay. Screen. Yeah. And the results were drawn based upon the local recurrence. So if you see here, sir, the local recurrence staging, rather they mentioned that MP-MRI has a high positive predictive value and accuracy. We see up to 92% seen. If you think and recurrence in the local region, like for example a surgery or radiotherapy post-surgery, if you see that. And if a PSMA PET scan is done, the sensitivity and the specificity is less, and the accuracy also is less in staging a local recurrence at the malignancy post-surgery or radiotherapy. But if you see the lymph node recurrence, the PSMA PET has picked up more amount of lesions, and the negative predictive value was close to 100, with accuracy going up to 90% in case of lymph node recurrence. Why? Because this has happened in view of low PSA levels also. The lymph node metastasis or lymph node recurrence pickup is high in case of an PSMA PET scan when compared to an MP-MRI. MP-MRI also has picked up the lymph node disease, but the accuracy is more with the PSMA PET. And extending the diagnosis to the skeletal recurrence also, see the bone scintigraphy, even though accuracy is more, but the sensitivity and specificity are even high with the PSMA PET scan also. So this shows that the metastatic diagnosis in case of lymph node and the skeletal post thing, that is a biochemical recurrence, PSMA PET would be the best option of choice to check for the extent of the disease and this management plan. So here they have given a reference values also, sir. In a PSA of less than 0.5 also you can see there is 50% pickup of the patients with PSMA PET scan. And the sensitivity has gone up to 85 to 86% when the PSA is more than or equal to 2. So this is what even this states in Campbell also. If the PSA is more than or equal to 2, obviously the sensitivity has been and diagnostic accuracy also increases up to 85 to 86% in picking up in metastasis. So is there any change in the impact of management? Yes, there is a change in management plan in more than 50% of the malignant patients with biochemical recurrence, what they mentioned. So 53% there is a change in management plan. So this is about the primary staging and well as the management. So what are the emerging indications of the PSMA PET scan? The other one is a targeted biopsy after a previous negative biopsy. So following a truss or following an MRI, you can fuse with that of the PET scan to have a better diagnostic accuracy of getting a positive biopsy. If you are doing an re-biopsy in a prior negative patient. Also, if you are planning a PSMA directed radiotherapy, staging before and duration during the treatment also, this PSMA PET would help us for better evaluation. And the recent advances, what we thought is the theranostics, where PSMA is being directed towards the treatment. This is also been under upsurge now. And also monitoring a case of a systemic treatment. Patient is on androgen deprivation therapy and you want to monitor the patient if the PSA is doubling time is high or progressing. Especially want to take about the CRPC patient. You can check for the PSMA PET scan to look for the metastasis and monitor his management. So example is the PSMA directed radiotherapy, prior imaging with the gallium-68 PSMA PET. Initial point of slides I mentioned, the small molecules are being under now study. Among them, the PSMA 617 and INT means they are mentioned as imaging and treatment. Sir. These are all ligands classification. So they usually classified them into fluoride based as well as the gallium and other based. Fluorides are separate and they need to have an separate chelator for that and separate chelator for these PSMA gallium other ligands. And lutetium-117 is being used as an emerging application in PSMA-directed radiotherapy. So here you can see in an CT image where there are significantly enlarged lymph nodes. Here, this is a patient with 77-year-old with metastatic castration-resistant prostate carcinoma who has been treated with prior ADT also. There is huge lymph nodes seen in the parietic region. And the images of DEF were post-treatment with that of the lutetium scan. So there you can see there is obviously may not be completely resolving, but they also state that it is a fall in PSA of at least 50%. They will look at the end of 1 year. So that is what they quote in the studies also. Using the lutetium-117 theranostics, fall in PSA of more than 50% in 1 year is usually they consider that as significant. So you can see there is an improvement in the lesion.
Karunakar, you know that first image,
Sir.
Don't call it a huge lymph node. It's a lymph node mass.
Mass.
Okay. Again, some finicky examiner will say you think it is one lymph node.
Yes.
It's a lymph node mass. Obviously, they are matched together, which the PSMA PET scan, if you see, has actually picked up at least 3 discrete masses.
Yes, sir. Correct.
Yeah.
And also in case of monitoring of systemic treatment in metastatic prostate carcinoma, what I mentioned there, previous indication also, the RECIST criteria, what we follow, the response evaluation of in solid tumors, response evaluation criteria. This is limited because many of them would not have a measurable lymph node or a bone metastasis seen there. So that would be the limitation in these imagings. And the disadvantage of bone scan also being the flare phenomenon, which may not be helpful in the monitoring whether the treatment has been fruitful or not. So for this also, I'll give an example here.
Yeah,
so
but
sir,
you know when the flare phenomenon takes place. So
yes,
the
sir.
bone scan can be done at a time when the phenomenon is subsided.
Okay.
So this is a bit of a commercial pitch.
Okay, sir. No, but here they have mentioned that if you compare the PSMA PET prior treatment and after treatment, you can almost make out that there is a complete response there in the bone. Whereas if you see a bone scan spec there, maybe this still shows there is a lesion still being stable. Rather, even though it has been completely resolved. And in a plain CT, if you see, that is a sclerotic lesion post-treatment which has been shown as still some sclerotic lesion being sitting there. So this they mentioned that as PSMA PET would be a better imaging modality in a patient with a systemic treatment to monitor his response to our management or monitor his treatment modality. So what they quoted was no absolute contraindication to do a PSMA PET scan. And in terms of radiation exposure, when compared to a conventional CT imaging and the PSMA PET CT imaging, you can see not much significant exposure of the radiation is also seen, sir. So I would like to give a key points.
A word of caution about radiation exposure.
Sir.
We might be looking at a single study radiation exposure.
Okay.
But we have to take into account, especially in patients who are on follow-up, that they might have undergone a variety of other radiation studies and radiotherapy. So all these have to be added before we decide whether we want to do anything which involves radiation.
Yes, sir. So the key would be the specific target. Since it is a prostate specific membrane antigen, it would be the rather specific target, and the most promising results would be there in staging as well as management also. And second one, which we discussed, was in biopsy negative patients, it definitely would be advantageous if you are planning a targeted guided biopsy. Sensitivity and specificity are also increased compared to the standard imaging modality. And also in case of low PSA with a biochemical recurrence, the sensitivity of PSMA PET is more compared to a cross-sectional imaging of CT or MRI. And also pitfalls, small recurrences in the urinary bladder cannot be made out, and potentially liver metastasis because high background activity. So you cannot make out that in PSMA PET cannot be very much advantageous in that. And neovascular of the non-prostatic cancers. And these celiac ganglions, stellate and other ganglions also means misdiagnosed would be of a lymph node sometimes because of the uptake seen in them also. And in the page disease of bone and ribs, as we discussed before, the sclerotic and the activity seen in that region may not be helpful to have a proper diagnosis of with the help of PSMA PET scan. So these, I would say, some of the pitfalls in doing an PSMA PET scan. And it is being extended into the other malignancies also. I don't want to discuss about them today, but even RCC and ablative radiotherapy being, they are using this PSMA also in ablative radiotherapy management also.
Just to add to what Mohan said about the radiation exposure,
sir,
most patients would have had a CT scan before treatment intent. And then they develop biochemical recurrence, and you go ahead and do. So you've got one CT scan, then you've got another CT scan trying to find out biochemical recurrence, and you may do a CT at that point. And then finally you do a PSMA PET. So, it's adding on. There's a lot of CT scan, and that radiation is adding up significantly to patients. It is just that these guys are old, so they may not live long enough to see the effects of radiation. But if you see children, then you are in trouble. That's what's happening to all the childhood tumors, isn't it? So we need to be extremely cautious about the amount of radiation that is being delivered to these patients by investigative modalities.
Yes.
Okay, folks, good show. This was
Thank
nice.
you.
But I hope you'll take this back and keep it in your minds.
Yes, sir.
Okay. Thank you all. We'll meet next week.
Yes, sir.
Have a nice time till then and stay safe.